All right, good morning, everyone. I'd like to welcome all of you to the Engelberg Center for Healthcare Reform here at the Brookings Institution for today's event on the state of accountable care, evidence to date, and next steps. I'm Mark McClellan. I'm a senior fellow here and the director of the Healthcare Innovation and Value Initiatives at Brookings, and we're very glad that all of you could join us today, both in the room and participating by webcast. We'd also like to thank C-SPAN for broadcasting this event today, and we'd like to acknowledge support from our ACO Learning Network here at Brookings and from the Merkin Initiative on Payment Reform and Clinical Leadership. These are two of our major initiatives on payment and improving care in the United States and around the world. This is a good time for today's forum. The idea behind accountable care is to pay for better quality care, better results, and lower costs at the person level. This is different from the traditional approach of fee-for-service payment for specific services and procedures, and it's intended to give clinicians, hospitals, and other healthcare providers more ability to customize the treatments needed by their patients, especially the treatments that are not paid for much or at all under the traditional fee-for-service payment systems. This includes things like spending time with a patient to discuss their condition, hiring a nurse or a pharmacist as part of a care team to help patients stay on their medications or change their behavior, or coordinating care across all of the different physicians and other healthcare providers that are increasingly involved in patient care. Clinicians get more flexibility in care, but they also have more accountability for demonstrating that they are getting better results and avoiding unnecessary costs. The physicians and other healthcare providers who take on accountability for the overall results and costs of a population of patients are called an accountable care organization, or ACO. And as we'll discuss, ACOs have been growing in Medicare, in private health insurance plans, and in state Medicaid programs across the country. Now, while this all might sound good in principle, there are some concerns. On the one hand, accountable care has been criticized as requiring too much change without strong enough support for it. Healthcare providers have to make real investments of time, effort, and money to change the way that they deliver care, with bigger changes requiring bigger investments, and the savings from better results to pay for this don't come till later, if at all. In this view, the idea of shared savings is not enough of a change away from fee-for-service payment to be able to support innovative payment models. Instead, a bigger shift away from fee-for-service towards more capitated payments, more fully person-level payments, as in the Medicare Advantage program for private health insurance plans might be needed in this view. On the other hand, others are concerned that movement away from fee-for-service payments in ACOs to make them would make them look too much like a replay of the managed care plans of the 1990s that were viewed by the public as skimping on care. In any event, there's a wide range of ACOs in existence today and a wide range of early experience and growing evidence behind the programs. Finally, many hospital-based accountable care organizations have been viewed as part of a trend towards consolidation in healthcare, which many view as leading to higher prices. So what we're going to do today is look at some of the latest evidence on accountable care, discuss strategies to overcome the unique challenges that ACOs face in succeeding in their mission of better health and lower costs, and also to provide an overview of the ongoing accountable care reforms across the country. Here at the Engelberg Center for Healthcare Reform, we've been working on issues related to ACOs and other forms of accountable care for quite a while through our ACO Learning Network and our initiatives on value and innovation in healthcare. And we're very pleased to bring together a wide range of experience and expertise from the public and private sectors to address these issues. The issues are very timely. Initial results of early ACO experiences are starting to emerge, and while better data are needed, it's time to start looking closely at what the data show and what it means for next steps for accountable care. We're also approaching the next major phase in the Medicare ACO program, with the next version of ACO regulations expected soon, and probably including some significant revisions. And both private insurers and states are taking the accountable care concept in new directions. All of this should be informed by the discussions we're having today. I'd like to just mention a few brief housekeeping items. As I noted at the beginning, this event is being broadcast on C-SPAN and via webcast, as well as being video recorded. A full recording will be available on our event page at Brookings Health in the coming days. We're also expecting to have some time for questions in each of our sessions, and we'll be using microphones in the audience for that. I encourage all of you in the room and those joining us by broadcast to follow us further on Twitter using the hashtag ACOFuture. Please also follow the Engelberg Center Twitter account at Brookings Med and the ACO Learning Network Twitter account at ACO_LN. So I'm going to start with a brief overview of some of the current ACO trends. This is an outline for the day. I'm going to start with a brief overview of the current ACO trends and results to date. Then we're going to have some opening remarks from Sean Cavanaugh, the Deputy Administrator and Director of the Center for Medicare at CMS. Sean's going to describe some of the latest ACO results in Medicare and some of the issues that CMS is considering in terms of the future of the ACO programs there. Next, we're going to have a panel discussion on what we know about the evidence on ACOs so far. We're then going to have a short break with refreshments out in the hallway. After the break, we'll reconvene here in this room for a panel on some of the big issues for ACOs going forward, and in that we'll focus on issues like engagement of beneficiaries. Immediately after, we'll have a final session on ACO policy issues and solutions on the horizon. So just to begin with a little bit of an overview of where we are with ACOs in the United States, over the past few years, the number of organizations forming ACOs has grown rapidly. Our own internal tracking shows over 640 ACOs in every region of the country working with commercial health plans, the Medicare program, and state Medicaid programs. As you can see from this chart, Medicare ACOs continue to outnumber private sector ACOs, but private plan ACOs have been growing steadily as well and are now part of almost every major health insurance program, health insurance plan in the country. In addition, 19 states are now in the process of implementing Medicaid ACOs. This slide summarizes some of the current take-up and results of ACOs. There is quite a bit of variation in beneficiary enrollment around the country and in the public and private sector, but it's becoming a significant part of both public and private insurance programs. Medicare ACOs now serve over 5.5 million patients, and commercial ACOs are providing care to 10 to 15 million beneficiaries through around 280 plans. In the results from these programs that we've seen to date, Medicare has released some results over the past months. I think you'll be hearing more about that from Sean. These results generally show better quality performance levels on those performance measures that are a key part of ACO reimbursement. And in the Medicare Shared Savings Program, the largest ACO program in Medicare, which represents this step towards paying in part based on beating a cost benchmark while improving quality, doesn't take away the fee-for-service payments that the ACO providers receive as well, but it does set up a second track of payment. In that Medicare Shared Savings Program, overall savings were around 1% or so in the first year with the significant improvements in quality. That's on top of the slow rate of growth that Medicare has experienced in recent years. And a subset of these ACOs, about a quarter, have achieved significant savings, large enough reductions off of expected trend to get some of those funds back, the shared savings fund back. I'll talk more about Medicare Pioneer ACOs in just a minute. I did want to spend a moment on private plan experiences so far. As you'll hear from our panel, these results are a little bit harder to compile comprehensively. Different plans report on their results in different ways and perhaps not as comprehensively as we'd like either. But if there is a basic finding that is worth noting, I think it's that many of these private plan ACOs do more than just provide shared savings up front. They provide more investment support through maybe partially capitated payments to primary care providers as in a medical home. They provide some infrastructure support, data, care managers, but in conjunction with that, they also expect more in terms of impact on financial performance, and that means more risk sharing. So instead of just shared savings, two-sided risk with the providers being accountable in part for holding trends close to overall growth in the economy or achieving larger savings and facing some downside risk if they don't. Many of these plans have shown some more significant impacts on savings, as well as in the Medicare case, some significant improvements in quality, with reported savings on the order of 2 to 12% in many of these major private plan implementation efforts. In Medicaid, the programs are at early stages, but some promising results there as well. Many of the Medicaid plans are also going beyond shared savings in traditional health care to integrate other types of activities, such as coordination with social services or behavioral support and other community-based programs that may have a bigger impact for some vulnerable individuals than just the medical interventions alone. This is a slide that highlights some of the early Medicare ACO performance. It shows the distribution of Medicare plans in terms of quality performance compared to the overall Medicare provider community. Most of the ACOs performed at or above the 70th percentile, so that's a shift on the slide to the right towards a higher level of performance on the quality measures that were established by Medicare for this program, particularly good performance in areas of patient experience and coordination of care, as you might expect. It's also important to note that there are a lot of different kinds of ACOs out there, some that are led by academic medical centers, some that are led by federally qualified health plans, some that are led by hospitals or integrated delivery systems, and a growing number that are led by physician groups, often primary care physician groups that are willing to take on overall accountability, but with a much smaller number of providers directly involved. And we're starting to see some differences in performance both across and within these categories of ACOs. The next slide highlights for the Pioneer program. This is, as you'll hear more about from Sean, a program for a smaller number of accountable care organizations that have been willing to commit to Medicare to move further beyond shared savings into some more significant financial reforms and accountability for both cost and quality. The ACOs that are continuing in the program are showing some further improvements in the second year relative to the first year. Again, this is percentile of performance. You can see the shift to the right on the slide. That's higher levels of measured performance. This is a chart for the Pioneer program that shows for their first 2 years results on both quality versus savings. As you can see here, and this is something that I think we'll discuss as well, many of the Pioneer ACOs, just like many of the ACOs overall, are doing quite well on the performance measures, so they're over to the right side of this chart, but some have not done as well in terms of achieving savings. And some of the Pioneer ACOs have dropped out of the program. As you can see from this chart, those are the ones that are the red dots. All of those are ones that did not do well against the financial performance benchmarks that were set up by the program. And one of the things that we'll discuss today is why is that? What's going on with the benchmarks? And is this really reflecting the ACO performance accurately, or are there ways to learn from this early experience to try to encourage better performance and lower costs at the same time? So that's a little bit of an overview. I would highlight that a good bit of this evidence came from our work with a range of healthcare providers, payers, associations, experts, and others through our ACO Learning Network to compile some of this evidence and share experiences. I'll have more to say about that a little bit later. But what I'd like to do right now is introduce Sean Cavanaugh, the Deputy Administrator and Director of the Center for Medicare at CMS. There, Sean is responsible for overseeing the regulation and payment of Medicare's traditional program providers, the privately administered Medicare health plans, and the Medicare prescription drug benefit program. Medicare collectively provides health insurance coverage for 50 million elderly and disabled Americans with a budget of over $550 billion. So Sean definitely has his hands full in his day job. Prior to assuming his current role, Sean was the Deputy Director of Programs and Policy in the Center for Medicare and Medicaid Innovation. So he came to the oversight of the overall CMS Medicare programs from some experience with the pilot programs like the Pioneer ACO initiative that I just described. And he there oversaw the development and testing of a range of new payment and service delivery models as well. Previously, Sean was the Director of Healthcare Finance at the United Hospital Fund in New York City. He's also served in senior positions at Lutheran Healthcare in Brooklyn and the New York City Mayor's Office of Health Insurance Access and the Maryland Health Services Cost Review Commission. He started out his career on Capitol Hill on the Ways and Means Health Subcommittee. Sean, we're very glad to have you here with us today. Please come on up.
Thank you and good morning. I'm going to speak for about 15 minutes and then leave about half the time for questions and answers, partly because that's what Mark asked me to do, but partly in recognition. I looked at the other panelists and the people here in the audience, and I think a very distinguished group, and in groups like this, people like me from the government should do less speaking and some more listening. So my remarks quickly, I just want to give you some very big picture context of how we think of the shared savings program. So starting at 40,000 feet and then coming down fairly quickly to the ground level and talking, as Mark indicated, about we are in development of a proposed rule for the future, the next generation of the shared savings program. So to talk to you a little bit about where that might be headed. So first, we're about 4 years out from the Affordable Care Act, and probably more importantly, we are 1 year out from the 50th anniversary of the Medicare statute passing Congress 50 years ago. So where are we? On the most important measures, which are controlling costs and improving the quality of care that our beneficiaries receive. Well, on controlling costs, the news is historically good. We are in the middle of about a 4-year period where the cost per capita of providing care to a Medicare beneficiary is essentially going to be flat for 4 years. Some of that's data that's already in, some of it's the actuary's forecast for next year. So unprecedented performance on reducing the growth in the cost per care. That bodes well for the program in many ways. One, the trust fund, the life of the hospital insurance trust fund. If you go back to 2009, the forecast was that it was 8 years from being exhausted, that it would be exhausted in 2017. This year, the trustees are saying we're 16 years from being exhausted, that the life has been extended to 2030. So that's good news. Also, I think when you control healthcare costs, it allows not just relief for the federal deficit, but also allows for better healthcare policy. Probably the best example is serious discussions now about getting rid of the sustained growth rate provision in the Medicare statute, which many feel has outlived its usefulness. But the discussion to get rid of it is only made possible by the low cost in Medicare spending. So that's the cost side. On the quality improvement side, again, historically good news. Hospital-acquired conditions, many forms of hospital-acquired conditions are dropping. Ventilator-associated pneumonias, early elective deliveries, I could go on and on. But lots and lots of signs of improvement in the care that our beneficiaries are receiving. Hospital readmissions dropping. So historically, 1 in 5 Medicare beneficiaries, about 19.5%, readmitted to the hospital within 30 days of being admitted. That's now in a precipitous decline, now about 17.5%. So what's causing all this good news? Well, there's a lot of factors. Some of it is public policy, both predating the ACA, but also things coming out of the Affordable Care Act. Some of it has nothing to do with public policy. It's changes that the professions and the hospitals and the delivery system have made on their own, because I think what you see is the beginning of a genuine quality improvement, performance improvement revolution in healthcare, which we've had in other industries, but sort of late coming to healthcare. We see actions by other payers, commercial payers, state Medicaid programs that are incentivizing these changes. So we're in very good position. We've got challenges ahead. How do we continue this level of performance and improvement? Well, first of all, the challenges ahead are significant. One, the actuaries, although they're predicting that Medicare costs will continue to be flat next year, when they look further out into the future, are predicting a return of inflation of about 5% price growth every year, which is a challenge for us. But more of a challenge is the baby boomers. In the next 20 years, we have 50 million, give or take, Medicare beneficiaries today. In the next 20 years, we'll add another 30 million. So 60% growth in the next 20 years. Very substantial challenge, even if we continue to control growth per capita. So that's sort of the landscape that we view the program in. We're in a great position in controlling costs. We have made some significant strides in improving quality, but we face very, very significant challenges. So I think that the way we look at the landscape is we need to continue to support delivery system reform. And how do we do that? Well, the Secretary Burwell, within her first 100 days, articulated a vision of delivery system reform, which was providing information to providers so that they know how to improve and know where they need to improve. Improving the incentives, so making sure all of our payment incentives support improvement, and building capacity within the delivery system for improvement. And I think the ACA has already initiated a lot of that work. If you see on the quality side on information, we're providing quality measurement in almost every one of our provider groups that are in Medicare. We're providing transparency with publishing these on our websites, whether it's Nursing Home Compare, Hospital Compare. And more importantly, and this is where I wanted to get to, is we're injecting the notion of value, of paying for quality and efficiency into all of our payment systems. And what are those payment systems? Very briefly, we have the Medicare Advantage program, we've got the fee-for-service program, and we've got new models of care that Mark referenced. In the Medicare Advantage program, a lot of progress. The Affordable Care Act, I think, set us on a course to pay more reasonably, so we're getting significant savings there. But at the same time, we're getting higher quality care in Medicare Advantage. 60% of Medicare Advantage beneficiaries next year will be in 4- and 5-star plans. Premiums have been essentially flat since the passage of the Affordable Care Act. So good news there. In fee-for-service, hospital value-based purchasing, physician value modifier, even in dialysis payments, we're building in the concept of paying for quality, paying for efficiency into all these fee-for-service models. But as Mark said, for many providers, they believe to truly achieve change and to fundamentally change the way they deliver care, they need to move out of fee-for-service and move into a different model. And that's where ACOs and other models come in. I'm not going to go into depth unless we get questions, but the Innovation Center is testing any number of models around ACOs, primary care and medical homes, lots of variations. I'll focus on ACOs, but as I say, it's an important part of our strategy on new payment models. So where do we stand on the ACO program? Early results, and I would use very similar slides to what Mark did. The early results are very promising, particularly on the quality side. On the quality side, it's pretty clear that most of the ACOs have figured out how to improve care beyond what's provided in the fee-for-service system. And we see that in beneficiaries. One of the measures we do is patient satisfaction. And patients in ACOs tend to be almost across the board more satisfied with their care than patients who are not in ACOs in the fee-for-service program. But there's more quantifiable measures. The pioneers from one year to the next improved collectively on almost all objective measures of quality. I think 28 out of the 33 measures they improved on. In the shared savings program, the shared savings ACOs outperformed fee-for-service in 17 out of the 22 measures where large group practices had reported quality measures. So in the quality story, very good, promising results. On the cost side, a little less, more of a mixed result so far, but I would caution that it's very early in the program. You recall, if you went back to January 2012, there essentially was no such thing as an ACO. And now we have, as Mark said, I usually use the number 360 in the Medicare program, but many more in the private sector as well, with 5.6 million beneficiaries participating in them. Several pioneers have clearly figured out how to generate cost savings and do that consistently from year to year. A number of shared savings ACOs as well. But the story is still mixed, and the question isn't, can the leading edge figure out how to generate cost savings, but can we get the vast majority of the ACOs in the long run generating cost savings to go along with the quality improvement? So, if the situation is promising but needs to do better, how do we move forward? Well, again, I go back to the Secretary's vision. We need to improve the incentives that the ACOs receive, improve the information, and help build the capacity of the ACOs. Since, as I mentioned, we're developing a new regulation for the ACO program, I can't tell you specifically. What I'll talk about now briefly are some of the areas where the private sector, the ACOs, have come to us, including through the Brookings Learning Network, and have told us areas where they think we could improve. And they map perfectly to the incentives, the information, and the capacity building. On capacity building, we've heard a lot of small practices that want to get into ACOs or are in ACOs need help in understanding how to transform themselves. And we've heard this outside the ACO community. How do we help small practices in clinical transformation? And that's something the federal government's talking a lot about. We even have spoken publicly about and solicited ideas. How could the federal government support small practices in transforming better? But specifically in the ACO context, one of the things we've heard is, well, since this is fee-for-service medicine, when we assign a beneficiary to an ACO in 1 year, many of them are not assigned in the second year. And then what some have referred to that as the churn of beneficiaries. So it's harder for the ACO to focus their interventions and resource investments on a beneficiary if they're not certain that they're going to have that beneficiary in the long run. And I think Mark made reference to some of the savings opportunities are in the long run. So we've been talking to many of the ACOs, and we've been thinking long and hard, how do you get a more stable population for the ACOs? The challenge there, of course, is this is fee-for-service Medicare, meaning the beneficiary is not locked into a network in the current vision of what an ACO is. And then broadly, I think how do you get a non-churning is part of a broader category of how do you get more beneficiary engagement. And I would say this is true not just in the ACO context, but in any context where a provider is trying to provide care better and in a different way. How do you get the beneficiary engaged in their care? So they're doing self-care, following medication adherence, those sorts of things. On information, we've heard consistently that ACOs need better and more timely information from the Medicare program. We've been working hard to do that. We have a ways to go. I would say, though, in CMS's behalf, 2 years ago, we essentially were sharing claims data with nobody. Now we're sending monthly claims feeds to over 300 ACOs every month with data of over 5 million beneficiaries. This hasn't been an enormous change for how CMS saw its role, but I think it's been a successful one, but it has a ways to go, and I think working together we can figure out better ways to share information. And then most importantly, we've heard quite a bit of talk from the ACO community about changing the payment rules for the ACOs. One of the things we do is we don't pay on the first dollar of shared savings because there's a lot of variation year to year in Medicare spending. So we create what are called minimum savings ratios or minimum loss ratios, which is the first couple percentages considered just statistical background variation. Many ACOs have balked at that, feeling like they did generate change. It wasn't a statistical anomaly, and they'd like to be paid for that. One of the things that's implicit in all the numbers Mark shared on who generated cost savings is what is the formula for what is a cost savings? The shared savings program followed the statute in the Affordable Care Act of using a national benchmark, meaning you start with the costs of your own beneficiaries historically, but you trend that forward based on what happened nationally in the Medicare fee-for-service program. A couple of things to observe about that. One is it's an interesting time to have started the ACO program because the fee-for-service program has essentially been not growing at all. So that's a very difficult benchmark to meet regardless. Two, a number of ACOs have said, well, I'm in a community where costs have been growing much faster than the national average, and it's not fair to only give me a benchmark that grows by the national average. The only thing I would say is we've been listening very close to these, but this was the point of contention in the drafting of the Affordable Care Act, and there's very delicate regional balances that come out in those discussions. But we are hearing quite a bit about whether the benchmarking methodology is the one we should stay with. We are proposing that ACOs that generate savings over a number of years and then continue in the program, that we would do something called rebasing, which is we're using a historical base period, we'd roll that base period forward. Some ACOs feel like if we keep rebasing them over time, their opportunities to generate savings will be diminished. So we're hearing a lot of ACOs asking us either to not rebase or to approach it differently. Mark made reference to a lot of ACOs want to provide care differently in ways that aren't paid for by the Medicare fee-for-service program. And they can do that, but they're not paid on a fee-for-service basis when they do that, so essentially they're investing their own funds. So we've been asked by the ACO community for a number of waivers, meaning they don't want to have to follow the 3-day prior hospitalization rule in Medicare. They want more generous access to the home health benefit. And then finally, and probably most conceptually tricky is, as Mark said, many of them want to not be paid during the year on a fee-for-service basis, but would prefer to be paid on a capitated basis. And that would free up the dollars for them to do a lot of innovative things. As I said, it raises some conceptual challenges, which is, would the ACOs then be like an MA plan making payments to other providers? Would it imply that there's a network? But these are all interesting ideas, and they're ones we're taking very seriously and considering as we propose a new rule. We're hoping the new rule will be out shortly so that the public could comment on it. We will go through the normal public comment period, which was, if this would be a proposed rule, we would solicit comment and adjust the rule as appropriate to public comment and hopefully have a final rule early next year. But again, this is, in conclusion, this is a major part of our strategy to continue the improvement on controlling costs in Medicare and improving quality. It's part of an array of strategies that range from Medicare Advantage all the way to our fee-for-service payment systems. But it is one of the keystones and one we're looking forward to working on with all of you. So with that, I will pause and take any questions. And I'm almost right on time.
You want to sit down, please? So while Sean's getting situated, there's a little microphone you can clip right on there. I'll just start with framing the first question. Sean, you did a very broad overview of fitting the ACO program into a wide range of payment reforms taking place in the Medicare program generally and in CMMI in particular. One of the things that you highlighted was basically that how important it is to think of ACOs as not just about a payment model, that there are other changes that are needed too. You talked about a lot of the regulations in Medicare's payment systems on things like no requiring a 3-day stay at a hospital before going to home health or post-acute care facility. Uses of home health services have typically been limited because of the restriction, because of the fee-for-service nature of Medicare payment. And you also talked about the need for further steps, especially for smaller accountable care organizations or smaller provider groups to be able to get off the ground in these kinds of big payment reforms. I know that more of this is going to come up in that regulation, which is coming out soon.
Soon. My official position.
Right. But you have made some other announcements recently from CMS, and the administration has, that pick up on some of these other issues. For example, just recently advanced payment program for rural ACOs. I wonder if you could talk more about that, maybe about the recent announcement from the Office of the Inspector General, I believe, about extending a program to give ACOs and some other providers that are participating in these new kind of payment arrangements a bit of a pass from some of the restrictions on sharing money across providers and the like, sharing resources across providers that, again, are intended to block some challenges in fee-for-service that may be less of an issue in these coordinated care approaches. Maybe you just could talk a little bit about how you see ACOs in the context of some of these other policy changes and where those might be headed as well.
Sure, and thanks for that question. And again, it was just part of what I was trying to say in my remarks is ACOs are important and they're big and they're a growing part of the program, but they're part of a broader strategy to improve care and reduce costs. On the specific topics you raised, we had, as some of you might know, created at the start of the shared savings program something called the advanced payment model. This was to recognize that there were a lot of providers who looked at the shared savings program and said, I get it. I think that's the right direction for us to go in. We can do well by our patients. We can improve the quality of their care. But we see that it requires an upfront investment. But we're just a group of small physicians or rural hospitals. We don't have the capital to do that initial investment. And so for want of that initial investment, we won't be generating savings for years to come and improved quality. And so to help some providers get over that hump, we provided what's called advance payment, which was, the name was chosen very carefully because what it meant was, this is an advance on future shared savings you're going to generate. So we gave it to 40-some ACOs, and we said, here's some money to help you through the beginning, to hire care coordinating nurses, to maybe beef up your IT system so you can improve care. But when you generate shared savings, you will pay this money back to the federal government. It's been very popular. Some of them did very well in the early rounds of the shared savings program. But we also heard that we left some groups on the outside when we designed the original one. We also heard that some shared savings ACOs were able to get into the program but weren't sure they could remain in the program without some help. So we tried to design the new round of advance payment to capture some who were in, who wanted to stay in but needed some help. But also rural hospitals, I think we really didn't define it right to get rural hospitals in, particularly critical access hospitals. On the waivers you were referring to, when we created the program initially, I mean, if you can think about the shared savings program, these are often not already integrated health systems coming together. These are independent practices and FQHCs and providers who are coming together for a common purpose. But oftentimes when they do that, they run up against some existing fraud and abuse laws about how much they're allowed to cooperate. So the original program included some waivers from fraud and abuse laws. Those waivers were due to expire this year, and the Office of the Inspector General has extended them for a year. And I think once we come out with the new rule and show where the program might be headed, I imagine everybody will go back to the drawing board and decide, do these existing waivers still fit the new program?
But it does sound like a longer-term commitment to making sure that the fraud and abuse protections are appropriate for the payment systems being used.
Yeah, I think you'll see continually, as the program evolves, continued reevaluation of have we tailored these waivers correctly to the way the program is operating and to what providers need and what the government's comfortable with.
And also quickly, in the same spirit of reinforcement of the basic ideas in an accountable care payment arrangement, we're seeing in the private sector a lot of insurers putting in a number of different reforms at the same time. So not just ACOs with shared savings or two-sided risk, but also medical home payments, bundled payments for specialty services and more advanced care, a number of payment reforms that all can be reinforcing. It's going to be a little bit challenging when Medicare is trying out some of these new payment models and trying to figure out what the effect of each one is. I think what many of the private payers are finding is they get more mileage by putting them all in together. Is that something that you all struggle with in terms of
We do, but as you know, the Innovation Center is testing many different models. We've tried to allow participants to participate in multiple models, including the shared savings program. There is one statutory prohibition, which is a provider cannot participate in more than one model that involves shared savings, so we try to be cognizant and enforce that. But certainly medical home models that don't involve shared savings and other models we think could be complementary. It does pose a challenge, as you say, for the proper evaluation of if you see a positive result, disentangling what contributed to that result. The one promising thing there is with the creation of the Innovation Center, we have much more robust evaluation budgets than we've ever had in the past. So we'll do better. It'll still be very much a challenge, though, to disentangle those effects.
I'd like to open this up to comments from some of you here in the room. We have microphones, so if you could put your hand up and then wait for a microphone. I'll try to get to as many people as possible. And over here, have the hand up first. Wait for just a second.
Thank you. Jerry Anderson, Johns Hopkins University. Sean, you mentioned the evaluation budget. So you've got a whole series of evaluations ongoing at CMMI. Some of the programs are working, some of them are not. What are the commonalities of the programs that are actually saving money?
So first of all, I'd say even I think I'm being rewired. I think it's too early to say. I apologize, but you know, the Innovation Center's first models went up January 1st, 2012. So, you know, to see measurable results best case scenario would have been like this time last year. That's if they had immediate substantial impact. And even then, it would be limited to the Pioneer ACOs and the Partnership for Patients, which was a big quality improvement. But the Bundled Payment for Care Improvement Initiative is really just getting off the ground now. Some of the medical home models actually do have some early results. Speaking qualitatively from what I've seen and not applying the level of rigor that you tried to teach me at Johns Hopkins, I think what you see is it's providers who are in this mode long before the Affordable Care Act passed, meaning providers who saw the problems with fee-for-service medicine but were pursuing the right form of care, communicating well with other providers, staying close to their beneficiaries, focusing particularly on the high-risk beneficiaries, long before all of our payment systems might have caught up to that, seem to be the ones who got going right out of the gate and did well. Those of whom are responding to the new incentives, I do think there's a learning curve. I think time before, and that's why when we talk about the shared savings ACOs, I think you have a mix of those. I think you have some that are coming in saying, this is great, this is what I always wanted to do, and some saying, this is great, this is what I've always been doing, and now I'll get rewarded for it. And so I think early on, you're going to see that diffusion of performance, but the hope and the expectation is the big middle will catch up.
For those organizations were committed early to this kind of approach to care, it's still important, though, to be able to have a sustainable business model to do that.
Absolutely.
And do you think that the shared savings program is enough to get there, or is your sense from many of those that they'd like to do more in the way of payment reform?
Again, I think there's a huge diversity out there. There's certainly a leading edge of ACOs that want to move as fast as possible to more financial risk, meaning almost capitation. Though they tend to want to get away from shared savings, meaning they want to budget, a prospective budget. They want capitated payments based on that budget, and they want to, let the government take a couple % off the top as a discount, and then they're on their way. I would say that's a small minority, but very large, sophisticated organizations. I think there's a larger group that are still feeling out what is the business model and what do they need exactly. But many of them clearly want better upside potential with less downside risk.
Time for another question up here on this side.
Thank you. My name is Li Yang, and when we are talking about evaluation of this store, whether there's budget or whether there's care, I have a very strong concern about it. Based on my research about hospital utilization and based on the personal observation, I just wonder if you can address the issues about accountability and the record and the real patient care. They say if you want to complain, the phone is not workable, and in writing, the response is totally absurd. And then you have a lot of abuse and unnecessary utilization, whether there is the catheter or anything like that, or even mental care. They have a private patient rights advocacy. They are paid by the hospital, but they are really absurd. They can even murder patients. So if you don't address this type of issues, the whole thing is meaningless. So could you really?
Yeah, I think you're making what is a point that I should have said at the beginning, which is our focus on cost containment needs to be matched by our focus on quality improvement. And I think we've tried to do that. But you're right. Anytime you create a new payment, every payment system has incentives, whether it's positive or negative, whether they move you in the right direction. But when you create payment incentives to increase efficiency, you need to have some confidence that your quality measures are making sure that efficiency doesn't come at the expense of the patient. With that, I would say, the results, at least so far in the shared savings program, are very promising. Patients are happier, seem to be getting better care. But whether it's the shared savings program or elsewhere, I think our measures of quality have a long way to go. And I think they've come a long way, but I think there's a long way to go to make sure we're really measuring things we care about and capturing. The other tension, I would say, is there's a tension in the shared savings program between those who would want to measure everything, meaning we don't want there any possibility something adverse is happening to this patient, versus the ACOs who are saying, don't drown us in reporting and measurement. Allow us to focus on things that really matter, that are just a handful of really salient measures. And I think that tension hasn't been fully resolved.
Right, and one that is, I think, part of the reason why you're doing so much work to try to expand out the scope of measurement while still reducing the burden on providers. Would just point out that there are a lot of aspects of patient safety where it's very much aligned with the reforms in accountable care. So preventing rehospitalizations, avoiding costly medical errors that lead to complications, all of those are steps that I think accountable care organizations, just like the hospitals that you mentioned, now that the payments for readmissions are being reduced, those organizations have stronger incentives to address. Are there any particular areas, though, where you're worried about the other direction, that the higher quality care may actually be more expensive, maybe for some subspecialty conditions where there are expensive treatments needed? Any particular areas stand out there? I know you're generally trying to pay attention to these issues.
Yeah. What I would say about that is we've had some technology firms, some medical device firms come and say, all this new payment is wonderful, but you're going to squelch innovation. And what we've said is, we don't want to squelch innovation. One, there's a type of innovation that, as you said, reduces costs. But even the ones that may increase costs but that are life-saving or life-enhancing, don't want to. So we're trying to find ways to measure that. We've been working closely with those industries to try to see if our payment system should adapt and allow, they've asked for a pass-through, meaning if we come up with something new, don't include it in the reconciliation whatsoever. We're not willing to do that. But we're continuing to focus on that to make sure, as you said, that particular type of innovation isn't being.
I'd like you all to join me in thanking Sean Cavanaugh for joining us here this morning. Sean, thank you very much. All right, and while I'd like next to go straight into our next panel and ask our panelists to come on up to the stage, we're going to talk now about this in terms of the state of accountable care, what we know about ACOs so far. So this panel is going to explore in a lot more depth the kind of evidence that you heard about briefly in my introduction and in some of Sean's comments, the evidence on ACO implementation, practice, and results. While our panelists are getting seated, I'd like to introduce them. They include Michael Randall, the Vice President of Clinical Innovation for Advocate Physician Partners in Chicago. Randall previously served as Manager of Business Advisory Services and Hospital Operations for the Camden Group, a consulting group that provides support on strategic and business planning, financial advisory and compliance, and hospital and physician services. Next, I'd like to introduce Marcus Zachary, the Senior Medical Director for Quality and Population Health at Brown & Tolan Medical Group in California. He's primarily responsible for the strategic and operational oversight of medical services related to the ambulatory care network at Brown & Tolan and the ACO portfolio, which includes their Medicare Pioneer program. Within Brown & Tolan, Dr. Zachary helps design and drive initiatives linking quality, utilization, and information technology in pursuit of the triple aim goals of improving quality outcomes and reducing costs. Before being at Brown & Tolan, Dr. Zachary was lead physician working on implementing electronic records and informatics for Dignity Hospital in San Francisco. Next, J. Michael McWilliams, glad you could join us today too, down from Boston, is a associate professor of healthcare policy and a practicing general internist at Brigham and Women's Hospital. His research, he's an MD and PhD, focuses on healthcare spending, quality, access, and disparities in aging populations with chronic conditions. The overarching goal of Michael's work is to inform the development of healthcare markets, delivery systems, insurance coverage, and regulatory and payment policies that support value and equity in healthcare, and particularly in Medicare. Much of his work relates to evaluating accountable care programs, including the Massachusetts Blue Cross Alternative Quality Contract. And finally, David Muhlstein is the Director of Research at Levitt Partners. It's a healthcare intelligence business where he oversees the firm's quantitative and qualitative evaluation of the changing healthcare landscape. He studied the growth of accountable care organizations extensively with the Center for Accountable Care Intelligence at Levitt, and he leads the firm's study of geographic variation in healthcare markets. His research interests focus on applying a legal and legislative framework to evaluate the evidence of health policies for the benefit of government and private policymakers. Now, I've asked each of our panelists to start out with some opening comments for this session on how they see the evidence on ACOs emerging, any particular challenging areas, notable findings, what they'd like to see happen next, comments along those lines. Then we're going to have some discussion across the group and then with all of you here today. So if I could start with Michael Randall, please go ahead.
So first to start, Advocate, we're excited to be here to share our journey with you. I lead many aspects of Advocate strategy and operations. In total, we serve about 600,000 lives in our ACO. This includes commercial, Medicare, and Medicaid lives. In terms of how do we make the model more sustainable, I think you've heard some things that Medicare is looking at. I think commercial payers are also looking at. How do we design a model for shared savings that is able to support provider organizations to have funds available to invest in information technology and care model design? Before I get into those aspects in particular, I just wanted to share some of our results, both in the area of quality and also cost savings. So first, in terms of quality, on the Medicare shared savings side, we had our estimated total quality score. We saw that increase in 2012 from 79 to 86% in 2013. Of the scored measures, 21 of the 27 improved during this period of time. On the commercial side, also seeing improvements in quality. We track 8 key indicators for our HMO population. 6 of those 8 improved in 2012. We're still finalizing results for 2013, but overall a net positive improvement. 2013 was a baseline setting year for our PPO population. On the cost side, our results mirror that of the national experience for the commercial plans, both HMO and PPO. We're seeing a year-over-year improvement of about 1 to 3%. For Medicare shared savings, a little bit less, but our first performance year was a 0.2% improvement ahead of the national benchmark, all of which came in the last 6 months. So that equates to about a 0.6% improvement or about $3 million in net savings to the Medicare Trust Fund. To make the model more sustainable, we believe that there are 2 areas of focus. One is information technology, and the second is care model design. So in terms of information technology, it's very helpful to have the claims information. It gives us a glimpse into the total care that patients are receiving, but it's not enough. And so for us, we're focused on marrying up the clinical and claims information. One example of that has been our partnership, or collaboration rather, with Cerner, where we developed a new hospital readmission risk tool that has a predictive value that's 20% better than anything else on the market today. A second example of how we're trying to merge clinical information and claims data is our support in the development of a regional health information exchange. Advocate has supported this through leadership as well as investments of funds and in the model design of the regional information exchange. Anticipating that about 50% of the area hospitals will be participating in this by the end of the year. Starting first with the exchange of admission, discharge, and transfer data with clinical information to flow about the middle of next year. The second area to address is care model design. Like other organizations, we started by focusing first on our high-risk population. We designed an outpatient care management program today that employs over 100 care managers working in the field with our physicians to coordinate care for these patients. A second key program was investments in post-acute care services, development of a pan-SNF network. Advocate only owns one skilled nursing facility, yet we refer business to over 100 independent skilled nursing facilities throughout Chicago. And so for us to be successful, we had to identify those organizations that shared a common vision to improve quality and lead to greater efficiency. Looking forward, we recognize that we need to go deeper into the population health triangle to engage not only the high risk, but the moderate risk patients as well. We've done some of this through our patient-centered medical home implementation. We are implemented this past year 3 new pilot programs, one of which is a community health worker program. And as we look at 2015, we will be making additional investments in pilot programs. I think for you in the audience that have the ability to influence public policy or commercial development efforts, supporting the efforts to promote interoperability of data and the exchange of data, as well as research to understand what truly is having an impact and what's working would be the areas of focus. Thank you so much for your time.
Great. Thank you very much, Michael. And I'd like to turn next to Dr. Zachary.
Thanks for having me. So I'm Marcus Zachary. I'm from Brown & Tolan. I'm having a disconcerting moment that I'm the gray-haired guy up here on this panel. I guess I've reached that age. So for those of you who don't know, because there's not a lot of folks from California here, Brown & Tolan is a fully physician-owned and operated independent physician association, the largest in Northern California, over 1,700 docs. So we are truly hospital agnostic. We have no private equity partners. We have no hospital financial partners. We have, excuse me, a long history of managing mostly professional risk in a capitated environment. We, like Sean was saying, are interested in taking more risk, and so with payment reform that was happening with the ACA, we jumped right in. So we have shifted about 100,000 lives over the last 3 years into some form of a risk-sharing program, and that runs the gambit of alphabet soup. So we've got HMO, ACO, PPO, ACO. We've got a limited Knox-Keene for taking first dollar on Medicare Advantage patients, and then of course we're pioneer participants. And happy to say we were one of your red dots up there where we've achieved savings, significant savings actually, in the first 2 years of payout with good quality outcomes. And we're very proud of that. I think on a high level, what we'd like to see, I think one of the things is that I have worried about from the beginning is that if the payer's attitude is, what have you done for me lately, I think we're going to be in trouble. We're coming from double-digit inflation in the healthcare space, and now we're talking about actual savings. And there are a lot of inefficiencies, and there is a lot of opportunity to raise the C level, but at some point, it's only going to go up so much, and we will have to, I think, accept the fact that there will be some growth for inflation, also taking into account, again, Sean was actually quoting the exact figures. We know the baby boomers are really going to put a stress on the healthcare system financially and resource-wise. So I think there has to be some dose of realism that the remarkable performance that we've seen early on, at some point, that's going to regress to the mean to some extent. That doesn't mean we have to go back to double-digit inflation, but something realistic. And then I think the other thing, and this is just from Brown & Tolan's perspective, because we have been managing risk and our docs are used to it, we definitely would like to see the continued evolution for the opportunity to take on more risk and to get at that first dollar, which I think Sean was sort of alluding to. And it's not going to be for everybody, and I would caution anybody who is thinking about it to really understand your organization and your ability to handle that risk, because it's not easy. when we get into questions, I'd be happy to talk about tactics and strategies that we're using, sort of more into the weeds that seem to have been important to our success. But I think I'll leave it there for now.
Great. Thanks very much, Marcus. So we've heard about results to date from the standpoint of a couple of the major organizations that are participating in ACO efforts in both the public and private sectors, and I'm going to hear from a couple of the experts on looking at the bigger picture across all of the ACO experience in the U.S. so far. So next up for that, I'd like to turn to Michael McWilliams. Michael.
So I'll speak more from a research and policy perspective, as Mark said. And I'll comment on three things, two challenges and one as far as results go. And I think one of the key challenges ahead from a policy perspective is getting the benchmarking methodology right, the spending targets for ACOs. Under the current model, the incentives for ACOs to generate savings are quite weak, particularly because of the rebasing that's implied by the current rules. So if an ACO achieves spending in one contract period, carrying the current rules forward, that would mean that their spending target or benchmark for the following contract period would be lower by that amount. So to give you a sense of why that really diminishes the incentives, if you think about an ACO increasing spending during a contract period, a Medicare Shared Savings Program ACO, for example, that isn't facing any downside risk, they aren't penalized for doing that, and it increases their benchmark for the following contract period, and then they can receive a shared savings bonus for doing nothing. Under the Pioneer program, they are penalized for doing more, but again, there's that offsetting effect by the benchmark going up in the subsequent contract period. So for Pioneer ACOs, the incentives are more akin to fee-for-service with a lag. Then thinking about the fixed costs of investing in systems to actually control spending, the rebasing is that much more of a problem because it may be hard for ACOs to recoup their investments of investing in the right systems. So that is one challenge, and I know Sean and his team is working hard on a revamped proposed rule for the shared savings program. Another challenge that's related is that unless ACOs have more control over where patients get care in the ACO programs, that diminishes the incentives further. To give you a sense of that, we analyzed outpatient care patterns at baseline among ACOs and found, for example, that only 80% of patients that were assigned to one ACO in 1 year were assigned to the same ACO in the next. That's just over a 2-year period. Among the high-cost patients, that number was even lower, about 75%. So that instability, that churn in the assigned population suggests diminished returns on investing in specific patients. A lot of specialty care leakage. So even among the most specialty-oriented ACOs, we found that over half the specialty office visits were occurring outside of the ACOs. And then something we termed contract penetration, the proportion of outpatient care revenue that's devoted to the patients under the risk contract, that was only 40% in our study. So that suggests very weak incentives to roll out or implement changes that might spill over onto other Medicare patients. And we think that those spillovers are probably likely. For example, we found spillovers in Massachusetts from the alternative quality contract, which is a commercial ACO contract sponsored by Blue Cross Blue Shield onto the Medicare population. And then lastly, so those are two challenges that require some rule changes, if not some developments in the market, like Medigap select plans oriented around ACOs to help sharpen the incentives. And then thirdly, despite those weak incentives and the constraints that ACOs face, the results have been quite positive. I think there have been some fairly convincing reports of early savings. We have some results coming out soon demonstrating a positive impact of the Medicare ACO programs on patient experiences, including improved or more timely access to care, better overall care ratings among the complex patients that are more likely to be targeted by the care management programs, as well as patients perceiving their care to be better coordinated. So from my perspective, I think overall it seems like a good start, but some need for some changes, some new developments to make the program a true win-win, both for Medicare providers as well as patients.
Just one, before going to David, just one quick follow-up. Is stated as a research hypothesis. I think you're basically saying that if the the new financial incentives created by an ACO program are pretty weak because of things like churn or shared savings and no downside risk and the potential for losing out on that contract in the subsequent year. You're not going to see very big effects. You have done some work, as he mentioned, with the AQC, the Blue Cross Alternative Quality Contract, which is, I would think, bigger in terms of those kinds of financial incentive measures. Has there been bigger effects there? Are you willing to say anything about whether doing more in terms of these kinds of strengths of incentives will lead to bigger effects? Is there evidence for that?
So the AQC doesn't have that rebasing involved. So if an ACO is looking over a longer time horizon, the incentives are certainly stronger, and I think that's true among most of the commercial ACO contracting. So there's a negotiated budget, and it'll stay there, or there's at least no rule saying that it'll get ratcheted down every time savings are achieved. The AQC is rather interesting in that it was implemented in a very broad HMO network. So there are no restrictions or financial incentives for patients in the AQC to go to the participating AQC provider groups. There are, however, mechanisms, because it is an HMO plan, for providers to deny care outside, because the patients need to have primary care doctors, and the PCPs can approve or deny referrals. Anecdotally, it sounds like the AQC groups, the provider groups, have successfully, without those financial incentives, been able to sort of corral care in and contain it within their provider groups. Many of those groups are quite large relative to...
And more effects on savings as well as quality?
And so the evidence today from the AQC is real savings effects and real improvements in quality. So whether that's related to the stronger incentives or not, I think just remains to be seen. It's Massachusetts, so that's also a potential difference.
Well, still need more research, and I know, David, you've been doing a lot of work around the country on this. I really appreciate your perspectives on what the research has shown to date.
Sure. So I want to focus on three different areas. The first is the variability among ACOs. So when we talk about accountable care, it's often referred as somewhat of a homogeneous group of providers, but in fact, there's a lot of variability among them. There are ACOs that have 30 physicians, and there are ACOs that have 30 hospitals. And as you can imagine, they have very different needs, concerns, and approaches to managing a population. And so what we're starting to see is that when you talk about accountable care, it needs to be subdivided into the different aspects of the providers that are participating. And the reason for that is because they really have a different glide path. They have a different opportunity to progress toward achieving the same common objective. So if we want to provide better care, we want better patient satisfaction and lower costs, it can be achieved, but with different provider types, they're going to focus on different things. And they really should prioritize different things from day one. So that's one of the challenges, is that many of the ACOs are focusing on topic A, when really, given their individual structure, they should be focusing on topic B. The second area talks with the real challenge of becoming an ACO and managing populations. There are two kind of core broad groups of ACOs. Some of those have been in effect ACOs for a long time. They've been managing populations. They have relatively integrated services. They have somewhat developed HIT. And then there are those organizations that have been strictly fee-for-service shops in the past, and they're trying to make that transition. What we found is that it's a long and hard transition to become a population-focused provider group. And so it's not something that we expect organizations to make that transition over the course of the first year. It's not even something that's necessarily going to happen within 3 years. It's going to be an ongoing challenge. Some of the big challenges that they mention are obviously the HIT, what they should invest in and when. But probably the biggest challenge is just giving the provider buy-in. So you can imagine if you have a group of physicians that have been working on a fee-for-service basis for the past 20 years, and you say, now we need to focus on a population, getting them to change their practice patterns, getting them to work more as a team, getting them simply to change their referral practices is a challenge, and it takes a lot of time and effort. And so while we'd like to see results in the first year and have a good indication of whether ACOs are going to work or not, 1 year really isn't enough time if we're trying to evaluate the organizations that are trying to make that transition. The third thing to talk about is the strengths of the different types of accountable care programs, so Medicare, Medicaid, and the commercial. Medicare, what I really view as is an enabling program. It has a relatively low threshold to entry, so a lot of providers are able to go in and start to manage or start to focus on population health in the short term. Also, if you only have, if there's no downside risk, there's not a huge financial barrier or disincentive to enroll. And so while there are startup costs, it's really a way to enable a lot of providers to start to bear risk and experiment with this. On the commercial side, we think of this as a program that allows additional resources to the ACOs. A lot of the large commercial payers out there have a series of different contracts that they work with providers on. So initially, they're not in a full risk-bearing contract. They're not a full-blown ACO, but they'll do pay-for-performance bonuses, but it's a stepwise progression where over a period of years, they help train the providers in the skill set necessary to manage a population. And so it's really a longer-term track as opposed to just jumping in and being an ACO right away. On the Medicaid side, this is really where I see there's a lot of opportunity for states to push the accountable care movement. And the reason for that is that they have a disproportionate ability to force providers into bearing risk. And so where we've seen these states that have a strong focus on accountable care, we're seeing a lot of activity both within the Medicaid space and also outside of the Medicaid space. As providers are being forced to consider becoming an ACO for the Medicaid program, they'll want to look for other opportunities to experiment. And so those where they're afraid that the Medicaid program will move that way, the providers, for example, are more willing to just enter into the Medicare program. The last thing that I would make is that ACO growth within a market does not happen by itself. There's very much a lot of strong market dynamics at play, and you don't see an isolated ACO. When there's one ACO, all of the competitors in the market either form an ACO right away or create an ACO plan over the next few years. And so within individual markets, there's a lot of overlap in terms of the different providers that are participating, and it really is happening at a market level, not just at the organizational level.
David, thanks for summarizing a lot of evidence and experience quickly. Can I just follow up on the point about states and Medicaid programs? So you mentioned a lot of activity, including some fairly significant reforms away from fee-for-service payment. Anything you can say about the actual results from some of those programs so far? They are pretty early.
Sure. The one good example is Oregon. They've what we would consider to be the most aggressive tactic of moving their entire Medicaid population to CCOs or care coordination organizations. And they have seen generally positive results. They are mixed, but they are somewhat positive. There are a number of other states that are just starting this year to move their population, or next year, or even over the next few years. And so really preliminary results even earlier than the shared savings program.
I'd like to thank both of you for those research presentations, and maybe go back to Marcus and our other Michael to get a follow-up sense from you about whether that overall summary of the national experience with ACOs to date fits with your own. You all are obviously not at that early basic stage of just starting to get provider buy-in and making some of the initial investments. You all are both organizations that have been at this kind of approach to patient-focused care delivery for a while, but you're different kinds of systems. Advocate has a hospital base involved, and Marcus, you highlighted that Brown & Tolan is a physician group. Any comments on what you heard or points that you'd like to especially emphasize or clarify?
Yeah, I think particularly that point about the fee-for-service transition and it being a painful one. Spending a lot of time in California, I think sometimes get a little bit isolated. We're surrounded by groups that have been in capitation, managed care, heavily so, for a long time. And then when I have the opportunity to come out of the state, I meet folks who really haven't managed risk, and you really begin to get a sense for what that really means. You don't have any of the infrastructure that any typical organization, provider group, that I would encounter in California, in other states where there's just fee-for-service or heavily fee-for-service. They've never had to adapt. They've never had to develop these services. And so beyond what happens at the provider mentality level for the organization that's supporting them, there's a lot of work to be done. And that takes a lot of time, a lot of investment. But one point I do want to make, which I think is important, as a physician, one opportunity that I hope is not squandered in this is that the fee-for-service churn is so disaligned for the patient and the provider. And there really is an opportunity here where folks can get the right care with the right person at the right time. Physicians, if they're willing to give up a little bit of their autonomy and work in a team-based approach, will be able to spend more of their time working to the top of their license, and most importantly, spend a lot of time talking to the patients who really need them the most. I mean, that's what really drives me, what really motivates me to see this work through. And I'm fortunate that we've got a great group of physicians in our provider group, and I think that more than anything has to do with our success, but that's what I really work towards.
I'd just like to build on that, David's comments on what does it take to change culture of an organization. So you've heard, some examples shared in terms of physician culture. We too, while we've had 10 years of experience working with our physicians to improve quality through our clinical integration model, it's been a shift for our organization to now take a perspective outside of the four walls of our hospital. And to do that, we created what we call an advocate care index, population-based measures that all of our senior executives down to the director level, as well as on the physician side, create alignment for the organization to move towards improving overall quality and cost of care, regardless of where that care is delivered. In the physician office, the points about patient-centered medical home, supporting staff to practice at the top of a license. A cultural shift for our organization, has been actually physically placing care managers that we hire into independent physician offices. So that's a big shift in dynamics in that office-based environment.
And back to Michael's comments about the shift in your financial support to make those kinds of business models sustainable. I expect there's some challenges around, especially being a hospital-based system where a lot of the revenues have come from the kind of procedures that Michael was highlighting is maybe getting in the, that revenue getting in the way of making some of these changes. How have you dealt with that?
Yeah, so clearly the model needs to move towards taking costs out of the system, and that is through, I think there was a comment earlier about evidence-based practice, reducing unnecessary use, so that's a component of it. There's also a component of how do we achieve greater economies, and part of that's scale in terms of an organization, but also looking at greater efficiencies in terms of systematic change, marketing services, human resources, those types of aspects, supply chain. So we're on a 3-year journey to take out about 2% of operating costs each year to make sure that the model is sustainable.
I'd like to open this up to discussion from the audience as well. So we have a question in the back there. The microphone over.
Hi, Josh Seidman from Engelberg Health and the Engelberg Center for Payment and Delivery Innovation. Dr. McWilliams, I was really interested in the comments you were making about beneficiaries' experience of care. I'm curious if you or actually also the providers from the groups have any insight into whether some of the incentives in the sometimes critiqued CMS approach to beneficiary attribution and assignment are having an impact on how you're engaging beneficiaries.
So it's hard to know from the empirical analyses we've done what's specifically mediating the changes in patient experiences that we observed. As far as the mechanisms for patient engagement go, I doubt they're playing a big role. My understanding is that most Medicare beneficiaries are unaware that they're even in an ACO. They get this letter about data sharing that some are confused by and some throw away and some opt out of. But the patient experiences that are in the quality part of the ACO contract are very much more along the lines of CAHPS measures, overall ratings of care and physicians and how access to care is, whether physicians are interpersonally connecting with them, whether they think their care is coordinated. Those are things that I think the ACOs are probably impacting more through the systems that they're putting into place, whether it's new scheduling, referral, access systems, care management programs that are really focusing on the needs of the complex patients, rather than anything going on between Medicare and the patients. Now, this does beg the question, though, now how will patients view the Medicare ACO programs? I think certainly one concern is that if patients do not like the brand of care that ACOs are providing, then that would not bode well for the programs because they are voluntary, and that could lead to market share losses and maybe discourage groups from staying in the programs.
So Michael, Marcus, how much do your patients know that they're part of accountable care arrangements, or are they just experiencing care differently for other reasons?
Yeah, I think it definitely varies, and there's truth in that. There are beneficiaries who probably don't realize that they're in the program. Patient engagement is definitely a key element that needs to be executed on to be successful. And we also participate in some other CMMI innovation projects like IOCP. So I've had a lot of discussions with other provider groups, and it's interesting. The Medicare population is not one size fits all, that there is regionalism even down to the level of certain cities. So like for our group, reaching out sort of cold call style to beneficiaries was not well received, whereas in other communities that was acceptable and they were able to get patient engagement. So we've generally had to kind of circle back around to our providers and work through those offices to get to those patients. And I think to your comments that as far as patient experience goes, I think that we have put a point of emphasis in the provider groups for patient satisfaction. They get scorecards every quarter. It's part of their bonus and incentive program. So there has been some attention and some improvement there, but a large part is, as you were saying, you're creating a larger organization behind the providers, and the patient experiences all of that, and that is generally good. So that's a good thing that's coming out, even if it's not directly coming from Medicare or directly coming from the provider's office per se, patient is still benefiting.
And David, you highlighted the different types of ACOs and how that might mean different steps that they should take to achieve some of their goals. Presumably, better patient experience is a key goal for all of them. Any comments about differences that you're seeing and how they're approaching the challenge of more effective patient engagement and experience?
One observation is that I agree with Michael that there's not really that focus on telling them that they're part of an ACO, but it's really that benefit that they view by what is the provider serving. So they say we're going to provide additional care coordination, we're going to provide enhanced access with primary care, but it's not saying you are part of an ACO now, so that's not the marketing strategy. Across the groups, it really does vary, and it also varies across organizations. Some really don't put the patient engagement is a high priority. Others are trying to build their entire strategy around that. So a lot of variability across organizations.
Thanks. Next question up here and then in the back.
I'm Dr. Caroline Poplin. I'm a primary care physician and an attorney. And this is actually a follow-up question. I'm perplexed by the fact that the ACOs, many of them are getting high satisfaction ratings, and you're also having trouble with churn, that people are drifting outside the ACO. And usually sick patients who are happy with their care, what they're concerned about is being forced to change their provider rather than they want to stick with providers who know them and that they know. So I would think that would reduce churn relative to a sort of a wide open fee-for-service. And I'm curious about who is drifting away and if you've looked into why.
I can address that.
Go ahead.
So what you're talking about is the attribution methodology, and the joke I have is that attribution is the longest four-letter word in healthcare right now. It's an evolution in terms of how much data is being used and into the methodology and the logic, and I think that fundamentally is the issue at hand. And so what we experienced in Pioneer over the first 2 years is about a 30% turnover rate between people going out and people coming in. So it's, and I get, Doctor, the question that you're asking, and it's not as simple as that, and it's not just about the relationship between the patient and the provider. It depends on, for instance, what doctors did you put into the attribution model? So for instance, we have 1,700 physicians in our network, but only 300 of them are part of the Pioneer ACO, and that was a strategic tactical decision that we made. So that's one aspect of it. There were some rules in the beginning about visits, how frequently they were occurring, and if they weren't occurring, you would lose the attribution. So that plays a role as well. So it's, and actually we found that for folks who aren't technically attributed to us, they're still going to see our physicians. They're still connected in our network. And that's not going to be true for, say, Orange County, where there's a tremendous amount of competition, more provider groups competing. The Bay Area, San Francisco is a little more concentrated. But so there's a number of factors that go into it, and I wouldn't take what you're hearing as an indication of dissatisfaction from patients. It's more about the attribution methodology.
Other comments on this? I know the attribution methodology and this issue of relationship to churn and the relationship of churn to beneficiary dissatisfaction is an important area. And I know all of you have thought about this.
I might just add that if there is increased satisfaction, then it may very well decrease the churn. I don't think we know that. We don't have a good handle on that, but there may be a sizable effect from that. And the other, I make one other point, which is that I think sometimes the knee-jerk response is to fix the attribution methodology, but that probably won't accomplish a whole lot without addressing the fact that beneficiaries assigned to an ACO have unrestricted choice of providers without any incentives to direct them back to the ACO providers. And we just know there's tremendous care dispersion among beneficiaries in part for that reason, and that's sort of what the ACOs are up against.
Other comments on this? Okay, great. And a question up here. Hold on the front of the room much yet.
Hi, Maury Menaker from Hackensack. I heard Sean discuss very, very briefly information, and his comment was that monthly they were supplying claims data to the ACOs. But we all know that the claims data from CMS can be up to 12 months delayed. So even if you're getting it monthly, you can't accurately predict what's happening with your population and make changes. Now, we've had some brief discussions about health information exchanges and data sharing. But it seems clear to me that the successful organizations, be they ACOs or not, are able to share data, clinical data, and be able to make appropriate decisions based upon that information. But yet, the government, with all its regulations, has absolutely no regulatory oversight over electronic medical records and transfer of information, and has sort of left that to the private sector. And the question is there a mechanism that we can utilize to improve data sharing to be able to really change our ability to quantify best practices and minimize wasteful spending?
I do think we're going to come back to policies, new policies around information technology and data sharing later. I would like to ask, I know both Michael and Marcus emphasize the importance of information technology in everything that they're doing, but what is the state of the research evidence on the extent to which better access to data whether it's through health information exchanges or other areas, translates into better or greater success of the ACO efforts? Or is that just another area where the research is limited? I'm asking David and Michael to start on this one.
So this is more observational data. The first is that information technology is still very much a work in progress with most organizations. So most of them have an EMR that works. They're able to look at patient-level data, but being able to aggregate that to a population and track that over time is more challenging. There's a lot of investment right now going into predictive analytics and care management platforms. But again, whether or not they're choosing the right platform or they're doing it at the right time is still to be determined. So there's a lot of kind of push and pull among ACOs about how they're going about this. One other observation about information exchanges is that the primary focus of the organizations is sharing information within the organization as opposed to sharing between organizations. The focus is trying to keep people in network and communicating between people that are quote unquote on the same team. And so the focus right now is how do you make sure that your outpatient is talking to your inpatient, particularly when you might be on different EMRs. We know of ACOs that have over 20 different EMR platforms that they're just trying to integrate and speak amongst themselves, let alone trying to bring in all the other outside platforms.
I would just add quickly, it's a major research challenge, and I think that the data that David's group, for example, is collecting will be a major contribution to allow really rigorous analysis on that front.
And Michael and Marcus, any final thoughts on working effectively with CMS data?
Yeah, we've spent a lot of time working with their actuaries trying to sort of solve the black box. I think one last closing comment I would want to make is value-based purchasing is here. There was a lot of hand-wringing back with the election and the Supreme Court case, but by that point, particularly with deals like what DaVita did, it's very clear the marketplace has spoken, and folks that are doing fee-for-service now have got to start changing their ways because this is coming. It's in Medicare fee-for-service, it's in commercial now, and so it is imperative for their survival, really, that they start making the changes we're talking about here today.
Any other final thoughts from the panel? It is, with this fast-moving area and this fast-moving attention around value-based payment, it is a very challenging area for the research to keep up. And we very much appreciate the discussion that all of you had about the state of that research and its implications for further steps with ACOs. So I'd like to ask all of you to join me in thanking our panel for an excellent discussion. All right. We are now going to take a short break until about 10:45, where we'll reconvene with our next panel on big issues for ACOs going forward. As you can